the next session, which is going to actually be a multidisciplinary approach to a couple of patients. So I'd like to invite the panelists to come up. We have Shereen Ezzat, who's here as an endocrinologist, Janice Pasieka as a surgeon, Simron Singh, medical oncology. I don't know if John is here. He may not have. I think we lost him earlier this morning, but we have Jean-Mathieu Beauregard for nuclear medicine. Yes, here, good. So obviously multidisciplinary. I am a pathologist. I'm not actually probably going to be involved in too much here because the diagnosis is made, but we're going to be talking about how to manage patients. And of course, pathologists have to keep all of these guys in line, right? So I think we have two interesting cases. We are supposed to have 45 minutes, but we're standing between you and lunch, so we're going to try and do this a little bit more quickly than that. And if we could have the slides, please. The next one, let's go to the, here, I think I can control that. So I'm going to let the docs talk about this, and I think, Shereen, you probably provided both cases. So why don't you give us the story?
Okay, good morning, everybody. Sorry, it's not that I slept in. I actually just came in from London at another meeting where I was talking about neuroendocrine tumors, so I apologize to everyone. I'm sure Calvin gave his same jokes. I heard just some of them. Yes. So what I've done here is actually I've put two cases together, and actually they're real cases. I've changed some of the details so that to maintain the anonymity, but they represent exactly the issues that we've had to struggle with. So to the rest of my panelists, I just want to make sure that you guys are on board here and recognize that this is a real patient. So this is a patient who is 69 years of age. He has other comorbidities, which we have to keep in mind, including diabetes, hypertension, and has had blood clots in the past going to the lungs. And has significant malabsorption. And you'll see malabsorption is important here because his initial diagnosis was back in 2003, where he had pancreatic obstruction as his presenting symptom. He underwent, as Calvin mentioned, a Whipple procedure. Now you know what that looks like. And the pathology from that time, at least we were able to identify that this was a well-differentiated neuroendocrine tumor with a Ki-67 of 2%. We're told that it was non-functional, although really the assessment at that time was less than complete as compared to what we do now. Fast forward to 2015, he now comes back with significant abdominal complaints, very similar to the initial presentation. And he's treated with a number of therapies, and it's a journey, as you can see here. Initially treated with a somatostatin analog, lanreotide, that showed no response either clinically or radiographically, and there was evidence indeed of disease progression. He then was switched to sunitinib, which resulted in significant complication of severe thrombocytopenia, and for that reason he had to be switched to another agent, which sometimes is difficult because of reimbursement, you know that. So he ended up on everolimus, where he had what is called a variable response, meaning that some areas actually improved while others actually progressed. So it wasn't like they were stable. And now, to my panelists, here's what we've got to deal with. The MRI shows extensive lymphadenopathy, and again, Calvin showed you some of the images there, located at multiple areas, as you can read here, at the root of the mesentery celiac region, in the IVC. Left renal vein also has multiple collaterals consistent, again, with the earlier disease I described. But luckily, at least, there's disease wrapped around the renal artery, but no thrombosis within it. So the question is now to the panelists. Next slide. How would you approach managing this patient now? So maybe perhaps now that we have a complete set of specialists, maybe we start with Janice. Do you want to, anything, let's get that out of is there anything of a surgical nature that can?
You want to get surgery off the table right from the beginning.
Well, look, it's getting back to the issue of having to look at all options at all times.
Absolutely, and I think the first thing is we would like to see the actual pictures. Just reading the description is not how surgeons work, so it would be a visual. But your description tells us of a very extensive amount of disease that is involving several different organ compartments, and the chances of us being able to resect that for a complete cure is probably nil. The question becomes, can us as surgeons help with whatever our next goal, our next line of therapy? Can we debulk some of this? Can we provide some way of decreasing the tumor burden to help with whatever this group decides? Is it medical? Is it PRT? Is it immunotherapy, or a combination? And we have to put it into the sequence. I also just want to point out that kudos to the surgeon that did the Whipple operation. The patients did well for 12 years, and had a lot of comorbidities going into it. So that first decision was probably a difficult one to take.
Very good point. So do we want to move to maybe Simron? Do you want to go on the medical side?
Sure. So I think this patient has had the 2 biological therapies that have been proven in large randomized trials for pancreatic NET, as we talked about this morning. If we need to move on to the next step, if it looks like the everolimus isn't working, we're out of the realm of where we have sort of proven large-scale trials, but we do have evidence that capecitabine and temozolomide is probably an effective option, as Hagen talked about this morning, for pancreatic neuroendocrine tumor. I guess we do have to worry about toxicity again, and in this patient we'd specifically worry about the platelets. That last slide, when they talked about that complicated by thrombocytopenia, that means the platelets were low. Platelets are important cells to help us to prevent bleeding, so we'd have to look at that. PRT, I'll let our panelists talk about that. Immunotherapy, I think this is a new emerging exciting option. We have no evidence right now that we know immunotherapy works in NETs, but as I mentioned this morning, this patient would qualify for 2 of the trials that were opened up at Sunnybrook looking at immunotherapy. So if this patient was motivated for clinical trials and to look at new experimental therapy, I think that's something we definitely discuss with him or her.
Dr. Beauregard.
Before even talking about PRT, we need an octro-scan or a gallium scan. So do you have at least a report?
Okay, so we have actually we have an earlier octreus scan that was done from 3 years earlier, and at that time some of the disease was positive. So the question would be, would you
Was it some but not all?
Correct.
So definitely, in the interval, the patient had new treatment, so we absolutely need first a new assessment, because those treatment may have impacted on somatostatin receptor. Maybe the negative receptor tumor shrunk, but the one that progressed was positive, or the opposite. So definitely we would first need another scan. Let's assume that we do a gallium-68 scan in Sherbrooke or an octro scan elsewhere, and it is all tumors are positive. Certainly PRT, I think, would be a good option. I think the level of evidence might be comparable to TEM chemo, and then we have to factor in also potential toxicity. Typically, PRT is less toxic, although with heavily patients that underwent multiple treatments, including everolimus and sunitinib, often come to us with already low blood counts, including platelets, and that's one of our side effect as well, although it's generally mild, but if the patient starts with, let's say, below 100,000 of platelet levels, that may be a problem, although in those cases we would typically reduce the activity and the doses we would administer. But certainly I think it would be an option. As I said in my talk, typically we have better response in PNETs than even in mid-gut carcinoids in terms of objective response or tumor shrinkage, so that might be an effective option.
Would you
So-
also do an FDG PET, though, as well, to sort of look to see about the difference between octreotide uptake and PET uptake?
Absolutely, particularly if the octro scan or the gallium scan shows that all the lesions we see on MR are not octreotide avid. That would be the indication to do an FDG scan to see if there's discordance, because the tumor that do not light up may be dead. So that's the so if they are not lighting up on FDG, they might be just sequela of prior treatment.
I just want to add one other thing. I think it's very important what you mentioned is about the sequencing. So in many of these cancers, we don't know what the right sequence is. You know, which treatment should we start with, what we shouldn't. And I think part of that drives that is trying to understand what potential side effects that may close doors to other therapies in the future. And I think that's a very important point that we should emphasize, is we want to also consider, as we're looking at the different options, and ask the question, is giving this treatment potentially closing the door to another treatment down the road? So we need to think of the long-term picture as well.
So along those lines, I'm surprised that none of you, maybe I'll throw this back to the chair here, of when we should be going back to look at the tissue of this patient.
That's what I was just going to ask.
So
Where's the pathologist on this?
predominantly, so to some extent, we're kind of looking at the imaging and we're looking at functional studies that provide some really surrogate information. And one of the issues, obviously, so maybe my questions would be, number one, how often in this setting, with this scenario that I described, do you see a significant change in the pathology as far as the grade goes? That's number one. And number two, is there any other added information that can be used, getting back to the earlier question about sequencing of therapy?
So actually, that's really a great question. We know that there's tumor heterogeneity, specifically in things like proliferation, Ki-67 labeling indices. So again, getting back to what we were talking about early, we can use surrogate markers with, for example, FDG PET, to see if cells are proliferating more quickly, or we could do biopsies to see whether the tissue has actually changed in its morphology. And I think that's always important to keep in mind for any patient who's going to go on to a new therapy. I was going to ask Dr. Singh specifically about the immunotherapy. In most other tumors, before we give immunotherapy, we actually biopsy and determine whether or not there are specific markers like PDL. Is that going to be the case in the trial?
It's a really good question. We're doing, so as you know, in some cancers, the biological markers such as PDL and PDL1 correlate very well with response, and in other cancers, we haven't been able to determine that. So we're looking at it in two ways. One is we are going to look at it in everybody, but still treat everybody, because since we don't know whether it's to predict or not, we don't want to not give people the benefit of the doubt. And the other thing is to look at mutational load. So for some of the high-grade neuroendocrine tumors, looking at the mutational load might be able to predict. But I think at this point, we still want to treat everybody and then try to determine if there's a way to help with that sequencing in the future and add to that literature.
And are those going to be biopsies performed at just before treatment?
Yes.
Not based on previous tissue?
Yep.
Great. All right, well, we have another case, so
Do you want to do the next one?
I think we should go to the next case, because we're between everybody and
But
lunch.
before we do that, maybe just open it to the audience. Does anybody have any questions or comments before we move to the next case? Go ahead. Oh, yes, thank you for asking that question.
Yes.
This is much more polite.
Normally, it's what the, and blank, and a few other blanks.
Actually, yes, this is what Tumor Board is all about, is the discussion of, we've got this patient, what are we going to do now? And usually we do have a cadre of people of this kind of expertise all involved, but more of us, hopefully, because we want more than one opinion from each group.
Sure.
What I've noticed in listening to people talk about PRRT is that there isn't really a lot of patients going through these treatments. And I wondered, is this patient actually eligible for PRRT today in Canada?
So the answer is the patient, the question has to do, is the patient potentially a candidate for PRRT? And the patient would be a potential candidate as part of the provincial trial in Ontario. The reason being that he has demonstrable disease with parameters that meet the criteria of progression. But one of the things that we would want to be certain of, as it was mentioned earlier, Pierrette, is that it's going to be safe. So one of the things that we actually have to do in many of these cases, especially that have been heavily treated with other therapies, is to make sure that we have very good measures of their kidney function, of their bone marrow function, know how we're going to rescue them if and when required as they go through treatment.
Okay, let's go to the next patient.
Okay, the second patient is going to be a lot easier, guys, okay? This one is 65, also a male. I'm not sure why, but so I apologize. I should have made that one a female. But he had surgery in 2016, so not too far back. Resection of the primary small bowel was performed along with a right partial hepatectomy, and also had radiofrequency ablation to some of the liver mets, as you had seen earlier, with a slightly different technology than what Calvin was referring to. The surgical pathology from that was, it was described, this is a very global description, not as finite as I'd like it to be, but it was a well-differentiated small bowel primary with a Ki-67 of 3%. Now, you can argue, are these Ki-67 from the primary, from the liver mets, from different, but the 3.6% was fairly representative of most of the samples.
I'll clarify that. We always, or should always, report the highest labeling, no matter where it is in any of the samples we look at.
So the imaging, and Janice, I apologize, I didn't get you the images itself, but I wanted them to be detailed so that everything is very efficient here. So segments 4A and B include disease that had RFA ablation, and now there's still some areas adjacent to them that represent residual disease. Again, relatively large, as you can see here. But no definite evidence specifically in the radiofrequency ablated zones themselves. Spleen, adrenals, pancreas, unremarkable, no ascites, no lymphadenopathy, lungs were clear, and the bone marrow signal was commented by radiologists as being unremarkable. So questions at this point, knowing where he is. So this is now mid-gut primary, you know where he's at, almost a year out. Options. Why don't we start with surgery? Is there anything else that he should have had beyond what was done?
So is this functioning?
Yes.
Yeah, so he has carcinoid syndrome.
Correct.
And so the goal at the first surgery was to try to decrease his liver burden as much as possible. And you can't get every tumor, and it's a balance at the time of surgery of taking out enough tumor, which comes with some normal liver, and leaving enough normal liver behind that will then continue with normal liver function. So sometimes it takes multiple surgeries or attempts to deal with the gross disease that we can see. My practice, I would also always take out the gallbladder if that's a safe thing to do at the end of all of this, mainly because they're going to be on somatostatin analogs lifelong, and there is an increased risk of having gallstones, and just going back in and trying to do a gallbladder operation years down the road after a major liver resection is not an easy task. So would have done that. I think before I would move necessarily with the options, I'd re-image that person and redo their biochemistry to see, is there still more tumor burden debulking or directed therapy we could do before we move to a medical therapy. Because sometimes the liver regenerates, and maybe it's more RFA or something else on the liver before Simron has to come in and help us up.
Okay, fair enough. Simron, you want to?
Yeah, I actually agree very much with what Janice said in terms of, going back to what we talked about this morning about what are our goals here. Obviously, our goal is to improve survival, but here, considering that this is a patient who's having a lot of symptoms that are not being controlled by somatostatin analogs, whether it be octreotide or lanreotide, our goal is going to be to improve quality of life and wanting to improve the symptoms. And a way to do that would be to try to reduce the bulk of the tumor that's producing the hormone. So I think, considering liver embolization for this individual patient may be a very valid option, because we really our goal is not only do we want to stop the tumor, but we want to make life better for the patient. If the patient, for example, wasn't secreting hormones, then I might change and I might think, well, then let's talk about additional medical therapy. So this is a really good example, Shereen, of how we want to individualize care. And in this situation, I think where the goal is to improve quality of life, I think liver embolization is a definite possibility. And hopefully in the future, we'll get more access and evidence about how PRT affects quality of life as well.
Beauregard.
Yeah, so of course, I would ask for scans. Assuming
Can't have any. It's Ontario.
send them to Sherbrooke. So assuming those two liver lesions are positive, and let's say for whatever reason it's not removable surgically, There would be, I would discuss PRT at the same level as any form of embolization. Now with the evidence, the strongest evidence with the Nether-1 study, that would be a perfect candidate for PRT. And even at our center, what I forgot to mention in our experience, we do our protocol allow for intra-arterial administration of PRT. So it's not embolization, but we inject all the activity directly in the liver, so there's more opportunity for the tumor to catch more of the agent. So that would be also an option. It cannot be less good than IV PRT. It's impossible. So it's slightly more invasive, though. So this is something to discuss with the patient, of course.
So one of the questions, let me pause you for a sec. You've already heard about the possibility of whether it's more RFA or embolization. How would you respond to the argument that if a disease is mostly liver-directed therapies should precede PRT, which can be considered more as a systemic type of therapy, and save that for later? The counter argument is that if you start earlier with systemic therapy, that maybe other areas of disease that were not as visible or as established, that perhaps that may, in the long run, prove to be more effective.
Yes, it's a good argument, and again, we don't know what's the best sequence, and it must be, I think, personalized for every patient, discussed with the patient. All embolization procedure are not necessarily easy to tolerate, whereas PRT is. So depending on the patient fitness, not necessarily age, because some older patient can be as fit or as younger, and the opposite. But it's all a question of discussing with the patient at similar or equal level of evidence after short-acting long-acting analogs. And everolimus, in that case, there's no other phase 3 proven treatment. So it's all a matter of discussing the pros and cons and risk versus benefit. And also, I think at this time, we discussed that earlier, it's better to sequence the treatment than trying to combine them, because we know these patients would still have a very long life expectancy. Right. So if we get everything in a short period of time at the same time, we may have less reserve for the future.
Jen?
One of the things that, I think the patients get frustrated as is the tumor board has to also understand the cadence of your disease. And that's such an important piece in making the decisions and trying to decide where we go next. And it may seem like we're saying, okay, we want you to recover, just do nothing for a little while we watch you. But if it's slow growing, we will have a different set of discussion as to what we do next. And if we see it rapidly progressing, then it change things. So sometimes we need time, and we need to look at it and see what's happening biochemically, what's happening with the urines and your symptoms, and then re-image while you recover from this type of operation. And that's an important piece.
So,
just a short comment. So you have the Ki-67, which is a very important piece of information, but when we have to remember it's representing the Ki-67 often of only one of the tumor, and sometimes you have multiple tumor that are heterogeneous. Sometimes you have low Ki-67, so at the diagnosis it would predict slower growth, or if you have a higher Ki-67, it would predict faster growth. But there's nothing like the follow-up, and fortunately with neuroendocrine tumor, we can afford to take the time to look at how prospectively the tumor will behave, and then take a decision later, because it's really common to see that the Ki-67 in the evolution is not concordant, and then even in a lower Ki-67 but rapidly growing, we can think about chemotherapy, and the opposite is true. A Ki-67 of 30-something, but it behaves more like a low G2 or G1, then we can consider other more appropriate options.
So let me I want to take that point further, and I want Sylvia to explain to us where everybody's happy when things are falling in place and it's predictable. Can you tell us more about why there's uncoupling at times? Why is it that we see a 3%er behaving like a low grade 3, for instance?
So I
why
think-
can there be such discrepancies?
I think Dr. Beauregard hit the nail on the head. What we see in pathology is, first of all, it's a static picture, and second of all, it's representative of the tissue that we have in the pathology specimen, which is the material that's no longer in the patient. What's left behind can sometimes be a little bit different. And I said these tumors are usually extremely heterogeneous. So a pathologist will stain 1 slide or 2 slides or 5 slides, depending on how eager they are to actually look at all the different components. You can imagine remembering what Dr. Gray showed us of a patient who's got all those tumors throughout their bowel and then multiple lymph nodes, and then there's lots of stuff in the liver. The pathologist can report on what they see. And we try to do as much as we can, looking at as many parts as we can, and we're taught to look and analyze the most intense area of labeling. But we don't know what's left behind and whether it looks just like what came out or does it look a little bit different. And so really, you're right, the real answer is going to be in the biology of what happens in the patient after the tissue is resected. We can predict many things, but we can't predict everything based on what we've looked at.
Just wanted to also add, added to this list, I just want to keep in mind that we also want to keep clinical trials, and I think we have to continue moving forward in that way. We were talking earlier how there wasn't clinical trials for NETs before, and now we're having a lot of opportunities, both locally, internationally, and I think we want to keep that in mind. You know, there's a trial going on now with like SBRT radiation combined with everolimus, and that this patient may be a candidate for that as well. So I just want to keep in mind that we always want to keep asking about clinical trials and pushing that envelope forward so we can develop new treatments as well.
So I'm a relatively dumb clinician here. At the end of the day, I have to sit down with a patient, and obviously they ask, so what are your thoughts? And the truth is that we do 2 things besides the imaging. On the logistic level, we also have tumor boards, and we have both local as well as now we have provincial tumor boards. But at the end of the day, it ultimately becomes a 1-to-1 type of discussion, maybe 3-to-1, usually if the spouse is involved. One of the things we have not talked about, which I think is very critical here, and that is the funding. Who's going to pay for what? When? Why? Why do we have issues, for instance, that stagger the sequencing in some provinces like ours? If you go on everolimus, you can't go on sunitinib if you have a pancreatic neuroendocrine tumor. So all of these are issues that unfortunately come as part of the realities of a world that we have to also filter in as we discuss all of the other parameters. And perhaps I want to hear from the audience here if anybody has any questions or comments about that.
That's a great question. The question is, how is it that sometimes you get one pathology report and then another pathologist looks at it and gives you a completely different report? The answer to that is kind of like anything else in life when you have somebody who's a generalist and you have somebody who's a specialist. And usually what happens with patients who have neuroendocrine tumors is that their primary pathology report is done wherever their surgery is done by a pathologist who may or may not see a lot of these. And sometimes they will elect to refer the case to an expert, or sometimes the patient will ask, or the clinicians will ask, or it will come to a multidisciplinary tumor board, and people will say, we need more information. Not every hospital has access to all of the tests that are available. Not every hospital has a neuroendocrine tumor expert. And, you know, like anything else in life, when you focus on something and you see it day in and day out, you get to know it a lot better than somebody who sees it once a month or once a year. So these, like anything else in medicine, it's a question of expertise, experience, availability of special tests that really allow us to give a patient something more than what they might have gotten on the first go-round. So many of you will have had secondary opinions, and usually that's because someone in your care group said, let's get the opinion of somebody who has more expertise. So the question now is, was the first diagnosis right? Was that really the primary, or was it something else? That's a great question, and maybe, I think, in the interest of time, I'm going to be the first speaker after lunch, and I hope I'll answer some of your questions in my talk, okay? I think then we're holding you back from a wonderful buffet that's right outside the door. I'd like to ask everyone to take this opportunity to enjoy lunch, and everyone who's spoken this morning who's still around will be happy to talk with you.